So we're going to talk about neurologic support today, and a lot of the things that we're going to talk about are things that you guys already do on a daily basis for all your patients. And when they first asked me to give this lecture way back, and I looked at the slides, it all seemed kind of different. But when I looked at it, it was all things that we do every day. It's just organized in a different way and presented to us formally. So the things that we want to cover today, we're going to talk about primary and secondary brain injury. We'll talk about a couple of basic concepts like intracranial pressure, cerebral perfusion pressure, oxygen delivery and demand. We'll talk about assessing patients, how we treat common things, treatment paradigms that go across multiple different pathologies. And then we'll look at a couple specific pathophysiologic conditions and see how those differ. So to start, we'll talk about primary brain injury, and that's pretty much what the patient's going to come to the ICU with. So they're going to tell you that a patient had a specific type of trauma or they had a brain tumor, so you already kind of know. But it's important to think about primary brain injury because you also want to think outside of the box. So when they present with you with something, you want to be able to carry it out the next step. And the important thing to remember is with these different mechanisms is that there's a variation within them. So a patient can present to you with ischemia. It could be a focal ischemia, like from a stroke, or it could be global. It could have an anoxic brain injury from a strangulation. You can have trauma. It could be something as small as concussive injury, or it could be something big, like a big intracerebral hemorrhage. So within all these mechanisms, there's a range of severity. And some of these also overlap. So in this particular patient, he has a traumatic subdural that's layering over here along the side, but it also has a compressive component to it. So in this particular case, there's two mechanisms that are involved. When you look at, and I encourage you guys to look at the scans if you can, because a picture is really worth 1,000 words. Like if you take the lady that's over in bed 3 now and you look at her scan and you see how big her strokes are, it gives you a much better understanding of how bad her pathology really is. So looking at the brain, it's kind of nice because everything's symmetrical, right? What you see on one side should be on the other. It's kind of like that Sesame Street game of which thing doesn't belong. So when you look at a scan and one thing is not symmetrical, you have to figure out what's not supposed to be there. On a regular CT scan, the skull is bright white, and then you have the brain parenchyma. And you can see here there's some extra white that's in there that's within that circle. That's an acute subdural hematoma that's pressing on the brain. And why is this all important to us? Well, it becomes important to us because what we're going to try to do is prevent secondary brain injury. So a patient comes in with a big hemorrhage, whatever part of the brain that hemorrhage blew up in, that's already damaged and that's not coming back. However, there's an area immediately surrounding it, which is called a penumbra, which is a silly name that you'll never ever hear outside of this room. But that's injured brain tissue, but it's potentially recoverable. And that's the tissue that we want to target our therapy at, to make sure that it doesn't progress to a secondary brain injury and give the patient more of a deficit than what they came in with. And you can see the list of reasons for primary secondary injury pretty much center around oxygenation and perfusion. So we want to make sure that they have both global and regional perfusion and adequate oxygen delivery. Because if they don't, what can happen, like in this slide, if the swelling gets worse, the compression gets greater, you end up getting a herniation syndrome. So moving on to intracranial pressure. So your head, your skull is basically like a closed box, right? And inside that closed box, there's brain, spinal fluid, and blood in the percentages that you see there. And your normal ICP, the upper limit of normal, is 15 to 20. And your body kind of keeps homeostasis and keeps that at that range. You can change the constituents. You can put a hematoma inside that brain. Some of the CSF gets displaced out the foramen magnum down around your spinal cord, so it decreases the amount of CSF that's in your head. You can get changes in the alteration of blood flow, and you maintain your ICP at around 15 to 20. There reaches a point in time, however, where that compensatory mechanism gets overridden, and now your ICP rises. And the reason that's bad is because as your ICP goes up, it leads to more compression, more ischemia, and promotes that secondary brain injury that we're trying to prevent from happening. Now, while we kind of focus on getting the ICP, and there's two different ways we get ICP, right? The most common way that you guys see is through a ventriculostomy. It's placed through the frontal lobe into the frontal horn of the lateral ventricle, and it gives us a nice pressure, the waveform. The good thing about a ventriculostomy is it also allows you to drain some of that CSF. So you can drain one of those constituents that's inside that closed box and lower down the ICP if you need to. The other way that we measure ICP is with a fiber optic catheter, right? That just gets placed in the frontal lobe and just gives you a waveform. and just gives you a number. Not only does it not give you, is it not a therapeutic modality, but over time that number tends to drift. It gets zeroed once it's put in, and it's never zeroed again. So for a while we were looking at that, and every time we took it out, we would find that the number would be +5, -5, +10. So the longer you keep it in, the more drift or inaccuracy that catheter is going to have, even with a good waveform. So while we always talk about, finding out what the ICP is, what we're really concerned about is their cerebral blood flow. And we can measure cerebral blood flow, but it's big pain. But one of the things that correlate with it is cerebral perfusion pressure, and that's a fairly simple calculation, right? So the cerebral perfusion pressure, or CPP, is going to be your mean arterial pressure that you're going to get from your A line, mostly from your A line, and you're going to subtract your ICP. So your normal cerebral perfusion pressure, or CPP, ranges about 60 to 100. And that's going to make sure that that area tissue, that penumbra, is going to get adequate oxygenation, right? Some of the trauma literature actually will even support a CPP as low as 50, but we want to target 60 to 70. So if you think about it, if you have a mean arterial pressure of 90 and the upper limit normal of your ICP being 20, that gives you one of your target CPPs of 70. So one of the things, after we talk about intracranial pressure and cerebral perfusion pressure, the next thing we want to look at is maximizing oxygen delivery and minimizing abnormal oxygen demands. And we see it very commonly. So things that cause abnormal oxygen demands or fevers, eventually if it's not on hospital day one, it's going to happen really soon. They're going to develop a fever. So we're really aggressive about antibiotics, antipyretics, even using things like the Arctic sun to artificially drop their temperature even lower as a neuroprotective thing. Seizure activity is a highly metabolic state, right? So you're going to chew up a lot of oxygen. So there have been a lot of studies that promote using seizure prophylaxis for 7 days after a head injury. Anxiety, agitation, and pain. Patients are always bucking and thrashing around on the bed. They're agitated. They're uncomfortable. They may be in pain. All those things raise your ICP and promote abnormal oxygen demand. Same with shivering and excessive stimulation. You look on the other side of the equation about maximizing their oxygen delivery. We want to make sure that their ICP isn't artificially elevated. Simple things to do is, so a lot of times trauma patients will come up, they have a cervical collar on, or they have one of those extrication collars on, and they always seem to never fit right? Their chin is like underneath or other that, or you want to make their chin stay on top, so it's wrapped really tight. When you're wrapping it really tight, you're compressing the jugular vein. You can artificially decrease venous outflow and elevate their ICP. The other thing is if their head is kind of tilted to the side, or if their head of the bed isn't elevated, it's going to make it artificially elevated as well. So if you loosen up the collar a little bit to the point that it provides enough support, but at the same time is not too tight, and trying to either keep towels on the side of the head, keep the head in the midline, and then keep the head elevated 30 to 45 degrees. For patients who have ICP monitors in, I'm sure you've seen it when you change their lens or do whatever care you need to do, when you drop them down, their ICP goes up. So that's a very simple thing to kind of promote oxygen delivery is by make sure that there's no artificially elevated ICPs. So we want to also make sure they have adequate oxygen transport, so that intubate them if they need to have oxygenation improved. We want to make sure they have an optimal blood pressure. So for us, going back to that equation, we want to see at least a minimal mean arterial pressure of 90 or better. And then, in the old days, we used to hyperventilate everybody, because if you hyperventilate them and you drive down CO2, they vasoconstrict. So you vasoconstrict, and that causes your ICP to go down. The bad part is when you vasoconstrict, now you're limiting oxygenated blood from getting to the brain, and we're worsening secondary brain injury. So we don't do that as a routine basis anymore. We do keep it on our pocket for patients who have, some intracranial hypertensive crises. We can hyperventilate them and bring their ICP down, so we get them stabilized and kind of figure out what the next step is going to be. But we don't do that on a routine basis anymore. The other way to promote oxygen delivery is make sure that they're euvolemic, make sure they're adequately fluid resuscitated, including blood if that's the fluid product that they need the most. So assessing the patient really is going to start from everything that you do at the bedside. As soon as you go over them, over to them, you kind of get an idea of what they look like, right? Are they awake? Are they talking to you? Are they following commands? Are they interactive? Are they totally sedated? And we'll talk a little bit more about the Glasgow Coma Scale in a moment, but it's a really good way to transmit information from one caregiver to the next, right? So somebody tells you that the patient has a GCS of 15, you know that the patient's like awake, a walkie-talkie person, you know, doing okay. If they have a GCS of 3, it's a totally different picture. Somebody who's comatose. Whichever test we do, whether it's a physical exam or whether it's a test of anatomy or radiologic exam, like a CT scan, we're going to do serial ones. So not only are we looking at one moment in time, we're looking at the big picture over time. So if their Glasgow Coma Scale is going to change by 2, that's a significant number for us. Same thing if we do a CAT scan and the CAT scan looks worse or looks better, that's really going to guide our therapy. So Glasgow Coma Scale, I know you guys see it and do it all the time. 3 different categories: eye-opening, verbal response, and motor. When they developed it, they decided to mess everybody up and give each category a different numeric value. So to help remember it, I always remember that eye-opening, I wear glasses, so people say I have 4 eyes, so I know that's the maximum of 4. Verbal, it starts with a V, which is a Roman numeral for 5, so I know that's 5 is the most in that one. And my car has a 6-cylinder engine, so I know that has 6. So the worst score you can get is a 3, right? That means you're comatose, and the best score you can get is a 15. And what we're looking for is a change of 1 or 2 points over time. It's going to tell you the patient's going to be doing worse. But it gives you a really good idea of how severe their brain injury is and what their picture is like when you walk over to the bedside. So what kind of initial interventions do we do? Some of these things we already touched about as we talked about the different topics so far to this point. We want to avoid hypotension. We want to keep their mean arterial pressure at 90 or greater, because that's going to help maintain that cerebral perfusion pressure. We're going to avoid hypoxemia by intubating them or providing supplemental oxygen. We're going to avoid jugular venous compression by releasing the collar if we can, keeping their head in the midline and keeping the head elevated. We'll maintain a normal PCO2 at 35 to 45 and hyperventilate them if we need to bring them down in an acute fashion. We'll use normal saline as a primary fluid. We try to stay away from the T5 to prevent if the patient has any vasogenic edema from getting that worse. We'll treat fevers as we need to keep that hypermetabolic state down. Sedate patients. We talked about using prophylactic seizure prophylaxis over the first 7 days. Another tool that we keep in our pocket to decrease ICP in acute phase is using mannitol. It's an osmotic diuretic, kind of dries out the brain, brings our ICP down. Something that we use not on a routine basis, but something that we use acutely to bring ICP down. ICP monitoring, we didn't talk about the indications for patients that generally have an ICP less than 8, or patients who have multiple traumas, who have a neurologic component, and their ICP may be greater than 8, but maybe they're going to the operating room for an orthopedic procedure or a laparotomy. You're not going to be able to follow their exam for a while or get a repeat CT scan in a short period of time, so you may want to monitor those patients. We want to keep their cerebral perfusion pressure at 50 to 70, and steroids are really never indicated for head trauma. So to talk about a couple of different pathophysiologic principles and how their treatments may be a little bit different than the ones we just talked about. So in this case, they have a 70-year-old guy who comes in, he's really hypertensive. He's 170 over 100. And has this CT scan where he's got a hemorrhage in his basal ganglia and it's extended into the ventricles. And how would his management be different? And the question kind of centers around his blood pressure. So, and it's kind of controversial, it's a double-edged sword, right? So you have a guy who's walking around who's probably hypertensive every day of his life, and that's the blood pressure that his brain's getting blood supply to, oxygenated blood supply to. Now he has an injury, and if we want to drop that down to like 120 over 80, now we're starving the brain of oxygenated blood that it's used to getting, and we're promoting that secondary brain injury. On the other hand, keeping his blood pressure at 170 over 100 promotes that hemorrhage to getting bigger. So we do advocate a modest reduction, like 10 to 20%. Certainly if they have cardiac effects from having elevated blood pressure like that, we're going to bring it down. We do a modest reduction based on what the pathology is. And we'll use like nicardipine, or you can use labetalol. But that's one of the things where it becomes a little bit controversial. Subarachnoid hemorrhage, the most common cause for subarachnoid hemorrhage is trauma. And that usually is up along the convexity. In this particular case, and when you see this kind of picture with all this bright white, down here is usually dark and filled with spinal fluid. When you see a picture like that and it's bright white, you're worried that they have an aneurysmal subarachnoid hemorrhage, which is the most common cause for non-traumatic subarachnoid hemorrhage. Those patients need to be treated a little bit differently. If you think it's an aneurysm that may have ruptured and now it's stopped, by keeping the blood pressure high, it's kind of pounding against this aneurysm and you worry about it rupturing and bleeding again. So those patients, we do want to control their blood pressure. In addition to the controlling the blood pressure, all that blood around the arterioles causes vasoconstriction. So calcium channel blocker called nimodipine that's given through orally or through an NG tube every 4 hours is the only medication that's kind of proven to kind of help minimize the effects of that. The bottom line is those patients need to go somewhere where they can be coiled or treated interventionally. Ischemic stroke, kind of important for us now since we started doing stroke intervention here at the hospital since February. So patients who come in who are known 4.5 hours from the onset of their injury are candidates to get angiograms and possible thrombectomies. Once you see a picture like this where it's all dark, that's an MCA distribution. Once you see a CT scan like that where it's really dark like that, you've kind of missed that window. You've passed that 4.5 hour window already. And again, blood pressure management is really going to be dependent on whether there's a hemorrhage there or not. For patients who present with older mental statuses, the other thing to consider is it's something that's either drug or alcohol induced. So we consider giving them thiamine, dextrose, or naloxone. Also electrolyte disturbances, we want to make sure that their sodium is okay as well as their renal and hepatic function. And for patients who have fevers and we're worried about an infection, we consider tapping them and then starting antibiotics once we get cultures. Seizures always makes everybody uncomfortable. Nobody wants to see the patient shaking on the bed. Makes the family really super uncomfortable, which makes us even more uncomfortable. So the first thing to do is get the family out of the room, and then we work on controlling the seizure. So the first thing we're going to do is going to break it with lorazepam, and then we need to make sure that they're on a continuous seizure medication. If they're already on Keppra or an anticonvulsant, then we have to consider increasing the dose because clearly it's not cutting it. The slide still has phenytoin and dilanthane on it. Everybody's really kind of gotten away from it. It's an agent that's really a pain to use. There's a lot of drug fevers associated with it. You kind of constantly have to check levels. If you're giving it intravenously, if you give it too fast, you can cause irreversible hypotension and bradycardia, which is very real. We did a craniotomy once. It was like a really long case. Patient got to the recovery room and had a seizure. We gave him Ativan, the seizure broke, and then we gave him an extra dose of dilanthane to kind of get the levels up. It was running in, patient seized again. Anesthesia said give him another 5 Ativan, so we gave him the 5 Ativan. They opened up the IV to flush the Ativan in, and it was the IV with the dilanthane running. The patient got hypotensive and bradycardia for a prolonged period of time and had a really bad outcome because of it. So it's a real phenomenon. We've really gotten away from it. Keppra really doesn't have any of those side effects. You don't have to check levels, no drug fever, so that's really the preferred drug of choice. The propofol that we use to sedate patients with, that gives an added benefit of seizure prophylaxis as well. But if you're going to use whatever agent you're going to use, you have to consider the effects of the blood pressure and respiration. Just ask Michael Jackson about how that propofol worked for his respiration. Spinal cord injury, really briefly, if there's a spine fracture, there's a 10 to 20% chance of having a fracture somewhere else, so we always look for that. Patients who have spinal cord injuries secondary to a spine fracture needs to be stabilized. We treat them appropriately. Any questions?
That was fast.
Well, they said 10-15 minutes. They wanted me to cover everything in neurosurgery in 10 to 15 minutes. But if you guys ever have any questions outside of this lecture, by all means, just grab us. If you want to see scans, we'll be glad to go over scans with you. Yeah.
So on our flow sheet for the patient, there's always a little controversy with labeling comatose on our flow sheet.
And obtunded and stupors.
So most of the time, if we're doing it, we'll modify that, and then some people will put comatose on there.
So what are you guys using as?
I'm trying to find a patient like bed 3, I guess.
Bed 3 to me is comatose.
Comatose.
And her GCS is 2. She doesn't really respond. She doesn't really do anything. We should actually have 3. She abnormally extends a little bit. but she's intubated, so it'd be like a 3T. So I would say that she's comatose.
So GCS below.
So it really, GCS will give you, so if you're 3, you're in a coma.
Right.
12 to 4 to 15 is a mild head injury. 8 to 12 is moderate, and then below that is severe. So it kind of gives you not so much that they're in a coma or not, but really the severity of their injury. I don't know what the criteria you guys use
It's just
for
confusing, I
and
think, for
stupors.
Yeah.
nursing, because I think if you look it up, comatose, you know, what sometimes the patients do stuff, sometimes they don't. So we tend to, the older ones that are here, will make a comment about exactly what they're doing, instead of labeling it comatose,
Mm-hmm.
you know.
Yeah, we can see maybe we can come up with a more standardized
So it's been confusing
definition.
for a while, yeah. Okay.
Yeah, because if it's not comatose, like if their GCS is more than a 6, but not a 10, they'll put like obtunded or stuporous, and you know, and we end up looking it up. It's like, well, what's the difference?
Yeah.
It's very vague.
Because sometimes you have a patient who's not moving, not doing anything, but they do open their eyes, but but they're not really following commands or anything.
And then there's lethargic.
Yeah.
Right.
Yeah. So it kind of depends on what term the person's most comfortable using, I guess.
Right.
Yeah, I
Yeah.
think that's where the
Yeah.
terminology.
Yeah.
Yeah.
Sorry if that was too fast.
No, thank you.